Good afternoon, ladies and gentlemen. I am very happy to welcome you to the EASL Patient Forum. This year, the forum is dedicated to health literacy to empower patients and address inequities. I will chair the discussion together with my colleague, Mr. Marco Korenjak, President of the European Liver Patients Association. I am Maria Buti, I am a pathologist, and I am the chair of Public Health and Policy at EASL. EASL has for many years worked closely with patients groups in fostering awareness of liver diseases and liver research. A year ago, EASL created an affiliation group called Patient Synergies to better consider patients' experience and better understand what patients need from healthcare professionals, among others. EASL works as well on promoting the prevention of liver conditions throughout advocacy work and the creation of educational material. This year, the forum will focus on the issue of health literacy to address inequities among patients. There are several definitions of health literacy, but it is based in the degree to which individuals are able to obtain, understand, and use basic health information and services that they need to make well-informed health decisions. As you know, Europe faces a health literacy crisis, with health systems increasingly difficult to navigate, even for more educated individuals. Actions are needed at all levels, and it is crucial to have patients' views and needs guiding the change. Thank you for joining us today. EASL values the importance of patients' groups' engagement, and I look forward to our continued collaboration. Thank you very much. Over to you, Marco.
Well, thank you very much, Professor Buti, for such kind words, and welcome also from my side. So my name is Marco Korenjak, as Professor just said, that I'm the president of European Liver Patient Association, and with all patient associations, we see that if patients are more educated, they have higher health literacy, this helps in any engagement with professional communities. We should stress that EASL has not just opened up its door to patient communities, but this was always open from the start to have higher engagement of patient groups, patient advocates, patients in the process of developing treatments, in the process of getting to new healthcare that would be better in the future for patients with liver problems. So today's event has the name Health Literacy to Empower Patients and to Address Inequalities. Of course, knowledge can empower you. And I'm sure that from today's discussion, we will see all different patient groups and we will see what they are doing in order to raise the health literacy, which is really important to have among liver patients. So without further ado, I welcome you to this webinar. I wish you a pleasant stay, a very interesting, sparking discussion among our speakers. And of course, maybe some really great questions that we can get from the public. And without further ado, I'm giving the floor to the next speaker to introduce by Maria. Thank you.
Thanks, Marco. We are going to have now two short presentations. The first one, it will be done by Professor Diane Levin-Samir from the University of Haifa, Israel. And she will deliver an introduction on health literacy. Thank you, Professor Diane, to be here today with us.
Thank you very much. I'm happy to be here, and thank you so much for the invitation to join this exciting meeting. I'd like to share a screen. Hopefully you can see the screen that I've shared. Can somebody give me an indication that you're seeing the shared screen?
Yes, it's perfect.
Okay, great. Thank you so much. So it is a privilege to be here. I'm not going to take any time to introduce myself, but just to let you know that I come from the background of public health, health promotion. I work both in practice in Israel's largest health service organization, which is Clalit. I work in academia, which is the University of Haifa. And I'm also the chair of the program of the Health Promotion Council in our Ministry of Health. So we work on policy and also working as an advocate globally in the global working group. So I'm really happy to share my perspective and our perspective, hopefully, on health literacy, whether coming from practice, coming from research, coming from policy, and also advocacy. And of course, patients are the participation of patients are important in every level, in every stage. So health literacy is not a new concept. If you do a word scramble, you'll see that it's related to so many other concepts that we work in. When we work in patient education, we work in health promotion, when we work in health education and public health and healthcare. And this, you can see the related terms. But just by way of definition, I'd like to give some introduction, maybe mention why it's important from the research that we know, and also maybe give a spoiler about what can be done and some conclusions and recommendations. And I'll just leave you with some food for thought. It's been exciting to try to put this presentation together because I kept thinking of more things I would like to tell you. So I'm going to run through it quickly so that I can hear the other speakers and that we can engage in lively discussion. So the definition is not new because it began, the first definition was in 1996. But since then, it has evolved, and there have been more than 40 to 50 definitions. The most updated ones I'm presenting to you now. The WHO has a health promotion glossary, and health literacy was updated as a definition, and you can see how all-encompassing it is. So health literacy represents the personal competencies, we're talking about skills, and organizational structures. So this is what we'll be talking about in a couple of minutes, why organizations are so important. And we're looking at resources and commitment, which enable people, again, as was mentioned before in the introduction, to access, understand, appraise, and use information and services in ways which promote and maintain good health. So this is a very all-encompassing definition. Plus, if we look at the Healthy People 2030 from the US, they've divided health literacy into personal health literacy, which is very reminiscent of what we've seen in the past, but also they've added the really important component about the responsibility of organizations. So organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, use services to inform health-related decisions and actions for themselves and for others. So we're seeing organizational responsibility, we're seeing personal responsibility for others. And just think about what that means, for example, when we're talking about Corona, COVID, and vaccinations, and it's easy to understand why it's so important. So using the model from Ruth Parker, this is just a lovely way to talk about the importance of health literacy, where it's really the meeting point between what people's personal competencies and abilities are, which we'll talk about in a minute, and also what's being demanded because of the complexity of healthcare, that many of us are understanding that our health systems are becoming more complex, perhaps for the better of the public. We're having more digital possibilities, and we'll talk about digital health literacy. And also there are many more subspecialties. We're not just talking about nephrologists. It's a pediatric nephrologist or a nephrologist who also has another subspecialty, and the public is being invited and being referred to the system that's becoming more complicated and perhaps more professional, but it does demand more skills. And it's relevant when we're talking about health, about lifestyles, for example, understanding a food label. When we talk about nutrition, it's relevant when we talk about taking medication, our self-care. It's relevant when we talk about interaction with the healthcare system, and particularly with our caregivers and providers, but also navigation of the healthcare system. So you can see how relevant health literacy is, and it's a relational concept. And if we go into it just a little bit more in depth, these are the elements of health literacy, where we want health information in a way in which we can find it, understand it, appraise it, to judge it, for example, and see how reliable it is, and apply it. And on each end, whether if it's on the personal end or if it's in the organizational end, we're seeing an array of different skills that are needed. The skills that people bring and that we all bring to the healthcare system and to the health of ourselves and our communities and our families, and also what the system needs to do a better job. But we'll talk about that in a minute. But when we talk about the individual, we also talk about the society, the culture, and we talk about situational aspects of health literacy. So if I can just go on, we know there's also a typology. If you can see here what Professor Don Nutbeam, way back in 2000, he said the health literacy has 3 different aspects. Of course, it's functional. And that's what we really would assume it would be. So people can obtain relevant information, understand it about health risks, about the healthcare system, apply knowledge in a range of activities. But it's not just functional. It's also being able to be interactive. To what extent do people have skills to interact with the healthcare system? Do they feel comfortable asking questions? Do we feel comfortable telling providers that we didn't really understand the answer? Could you please repeat it? Or are we saying, if we're asked to do a teach back method, if we're asked as patients to say, what are we going to take back to our home from it? We'll see that we're not being tested. It's just the provider, the doctor, the nurse, or whoever our healthcare specialist is, wants to make sure that they're understood. So that's the interactive part. And we know it is culturally related. Israel is a country of cultures, and we know that not every culture and not every age group feels comfortable interacting in a way in which they can make the most out of health literacy. And really important, especially during these times, is critical health literacy. Are people being able to criticize, to judge the information that they're getting? Take, for example, the issue of vaccines. It is such a hot topic because so much information is being relayed to the public. Many people are not understanding if the sources are reliable, if the sources are those who are interested in their health, or they have another interest which is motivating them to give the information. What are the reliable sources? And who do I go to find out if this information that's coming to me is something that is good for my health and my family's health? So that's critical health literacy. And of course, COVID has made it so relevant to us. If it wasn't before, it surely is now. Well, so how do we know what the scope of health literacy is, how we're doing as countries, how we're doing as societies? Well, there's a way in which it can be measured, particularly our US colleagues have the readability test, and they began in the 90s to look at how health literacy is measured, whether it's a test of functional literacy for adults or other readabilities, but those are for functional reasons. How are people doing getting information and understanding information? So that is one aspect. That's the functional aspect that we talked about before. But then in 2012, the European Health Literacy Survey came up with a different measure to look at general health literacy and ask people how easy or difficult it is for them to understand information, to gain information, to use it. How are they doing, or how are we all doing communicating? So it is really kind of a self-assessed way in which we're looking at health literacy. And this was really crucial because it was done among different countries in Europe, and we're able to see how countries were doing and what is the extent of health literacy, or low health literacy, or more adequate health literacy. But even before we see the European data, let's look at what was already understood from the United States and from all of the studies that were done to begin with, and then extended to Europe. We see it's so important because people with lower health literacy, and we know it could be a risk, but in a minute we'll talk about it as an asset. They use less preventive services, need more emergency treatment, have more hospital admissions, have more problems to understand health-related information, are less able or feel less competent to take medications correctly, and have worse self-management measures, are less able or feel less confident to co-produce in treatment and care and sit at the table with the others to work together on promoting health, have worse treatment outcomes and more complications, have more unplanned readmissions. And we even saw that the Institute of Medicine saw that it costs billions of dollars, according to the United States, for low health literacy. But the good news is that one of the determinants of healthcare that we can influence, and that's the exciting part about health literacy. It is a skill that we can influence, and it's also a topic that we in the healthcare system can work on to adjust ourselves, to adjust our systems to what people need for health literacy. So what happened in Europe? What we saw was that limited health literacy was really, if we look at the total here, we see about 1 in every 2 Europeans have a lower health literacy or insufficient health literacy. But of course, there's a division between countries. This is a 2012 data. I'm happy to say that we launched this week, which is a bit too soon for me to share it today, but the WHO MPOL, the measuring population and organization health literacy data, which was used a very similar tool, but in different methodology. And so the countries are now have looked at themselves, and you'll be able to see in another couple of weeks the report. But then let's also just mention digital health literacy. This is a newcomer, relative newcomer. It was called e-health literacy in 2006. We've updated the definition, which will be launched in 2 weeks. But it basically is a capacity to understand and evaluate health information from electronic sources. But way back in 2006, it was just internet. Think about the whole digital ecosystem we have now, which is really using wearables and using sensors and being able to access appointment systems through digital services. I come from, in Israel, we're called Startup Nation, and we're using more and more digital tools. But are we talking about digital development or digital divide? That's a whole nother issue that I'm happy at any point to discuss with you at a later time. It is an underestimated health issue, and it's also important to battle the infodemic. If I was to give this lecture 2 years ago, I don't think I would have talked about infodemic, but we know because of COVID, it's such a huge issue. But in any case, as the other definitions we've used for health literacy, it empowers people to process information and to use it for their health. And these are just some of the examples that we saw in the digital system and why it's so important when we know that there's a spread of misinformation, and that information can be harmful as the disease itself. There's a lot of fabrication, but it does reflect the public's thirst for knowledge and solutions. So we have to be there with reliable information and also be able to empower people to have skills to develop and to interact with the system or any other source. And so when we look at this, and just as the last point I would really like to make, when we go back to this model, we see that when it looks at the system, what has changed? It's not just universal precaution and seeing that looking that everybody potentially could be at risk for low health literacy. We're also going from the individual to look at the system. And I'm so pleased to mention the work of our colleagues from the United States, but also others in Europe have developed it more on organizational health literacy. And the health literate organization, the concept that was developed in 2012 and 2013 by colleagues from the Institute of Medicine and others. And the health literate organization makes it easier as organizations, as hospitals, as clinics, as systems. We make it easier for people to navigate, understand, and use information and services. And there's to take care of their health, of course. And there's 10 attributes. We now have standards, whether we're promoting leadership, we're planning and improving, we're preparing the workforce for being more health literate for patients to ensure easy access to information. We need to communicate effectively. We need to talk about coverage and costs, and target high-risk people, which we know there is a social gradient for health literacy. And that's one of the titles of this webinar. We know that there is a social gradient. People who are more financially deprived and lower education have lower health literacy, but not only do those people do it, all of us do at certain times of our lives. So we have to design and easy to use materials. We need to meet everyone's needs and include consumers and patients in what we plan and what we do. So we've produced some articles about what's been done during the pandemic. We know the tools that we have for health literacy are just as important, whether we're talking about chronic disease and NCDs, or whether we're talking about an infectious disease and a health crisis. And we know that digital health literacy, for example, we already have the recommendations for people with chronic diseases, how government and health agencies should be helping people access more information and more tools digitally, whether using traditional media and digital media, whether partnering with organizations to produce social media and video materials, whether we're talking about smartphone apps and partnering with digital platforms to make sure we're doing fact checks, false information, and communicating to the public the most reliable. So finally, we talked about the definition, we talked about measurement, we've talked about practice, and now just about policy. I hope some of you are policymakers or influencing policymakers. We all should speak up. And we've had position statements on health literacy that the International Global Working Group on Health Literacy has produced, and they're all available online. Where there's national action plans that are beautifully done. And for example, the one from Scotland, which is in its second version, and talks about why health literacy should be made, why it all should be made easier for the whole public. Austria now has a health action plan, Germany and other countries as well. We also see the WHO in 2016 as part of the Shanghai Declaration for Promoting Health. Health literacy was one of the main pillars. We know there's accreditation for healthcare systems through JCI, and I think there's more coming. We're seeing it becoming more on the agenda of health policymakers. And finally, the WHO produced the Solid Facts document, which is a policy document. And you know, if any of you are policymakers, when the WHO wants to influence policymakers, they call it the Solid Facts. So it was my privilege to participate in putting this policy decision-making evidence-based document together with many other colleagues, and it's also available online. So we want to see ultimately health literacy in all policies. And we produced the International Handbook on Health Literacy for any of you who are looking to see what studies have been done. 700 pages, 43 chapters, over 200 authors, and it's open access book that we produced about 2 years ago, and we're very proud to make it available to the entire community, whether you're a patient, whether you're a practitioner, whether you're a policymaker, and of course, all of us are advocates. So finally, we need all hands on deck. It is a global issue. So I'm really grateful for the opportunity to share some of these thoughts and some of the practice and the research and the policy with you all. I'm staying online, and I will be anxiously listening to the other presenters, and be happy to participate in panel and answer questions at any point I'm asked to. So thank you so much.
Thank you, Diane, for this excellent introduction. Let's now move to a more specific thing, that is health literacy on liver diseases. And for this, we have Dr. Marcus Romney. He is author of the book At the Human Edge, and I think he's the right person to talk about this topic. Thanks, Marcus. The floor is yours.
Thank you very much. Thank you. Lovely to be with you all. And as mentioned, I'm the author of the book At the Human Edge, also founder of The Human Edge, and in very many ways a misfit. Misfit, you could probably gather the fact that I'm sitting outside on a very cold winter's evening in London, getting some sunshine and steps to try and promote some better well-being for myself when I travel. But more than that, a misfit as a clinician as well, because very early on in my career, I realized that if a patient was sitting in front of me, then the system itself had broken down and we'd failed them. And so that started my pursuit towards understanding how we can each reach our human edge, achieve the most out of this biological machine that we've been given, and work with patients towards managing their chronic disease and preventing them from occurring in the first place. And I think liver and metabolic health is an ideal candidate for a topic and theme like this. Next slide, please. So if we look at how digitization has really been changing around the world, each of you sitting where you are right now, listening to me, are creating 2 megabytes of data every single second. And most of that data is being used to either sell you something you don't need or show you something on an OTT platform that you don't want to watch, etc. Hardly any of that is being used to your advantage to make you a better, healthier, happier version of yourselves. And we've certainly seen that through the pandemic, the digitization and the acceleration of this digital transformation around the world has just increased significantly, exponentially over the last 18 months or so. Next slide, please. We're seeing it reflect in the healthcare spectrum as well. The amount of money and investment that's going into digital therapeutics, digital health, mobile tech, etc., have vastly increased. And COVID as a disease has been one of those significant ones that have been impacted by this, right from patient tracking, information sending, measuring tests, managing consultations online, etc. Next slide. And this direction is something which is likely to stay for many, many years. I spend most of my time in India, and one of the things we're most proud of is how we've adopted digital technologies to manage the pandemic. And this slide beautifully illustrates this. I know we're a large base, so our denominator is very large, a population of 1.3 billion people, but our mobile app that was created and released in India for COVID-19 saw a adoption of more than 85 million people and an overall download of 127 odd million people, which is significantly larger than other developed world and developing world territories around the world. And certainly this idea of managing disease has begun to shift the zeitgeist, both for the consumer and i.e. for the patient and for the provider and the doctor as well. Next slide. But even with all of this acceleration that we've seen in the last 18 months, the overall level of literacy, as beautifully illustrated by my colleague speaking previously, is still dismally low. Right? In the US alone, it's just reaching double digits, about 12%. In India, it's about 8, 9, 10%. And certainly around the world, we have a long way to go in order to get this message out to patients and providers. And hopefully forums like this will move that in a positive direction. Next slide, please. So liver health is something that beautifully lends itself to this conversation, because as we all know, both from the patient side and the provider side, it is a multidimensional, multifactorial disease. And when I was in med school, it was spoken about as non-alcoholic fatty liver disease. Certainly we've discovered that certainly alcohol has very little small role to play. Advocates like Professor Lazarus and others on the call today are encouraging a new terminology adoption. But we know that liver disease ultimately has got many underlying physiological parameters: glycation, oxidative stress, mitochondrial dysfunction, insulin resistance, and many, many other things, all of which can be better managed through metabolic inputs and an upstream approach towards the prevention of sick care and disease in the first place. And that's why a conversation like this is just such a powerful one. Digital biomarkers, something that most of us are producing even without realizing, either through the mobile phone that exists in our hand, or the fact that the 1 billion white-collar workers that exist around the world, 33% of them are already adopting a wearable device like a watch on their wrist, a ring on their finger, or a CGM patch on their tricep, all of which is producing information about them, physiological information about them, which can be used to their advantage. And something that I often say tongue-in-cheek is that by Christmas Day of 2025, I believe that we might be in a position to know our patients better than they know themselves, physiologically and psychology, just through the triangulation and study of these different digital biomarkers. Next slide, please. So we've seen, I've spoken about some of these devices, and in the interest of time, I'll skip over this, but they are increasingly becoming more and more ubiquitous as companies led by the consumer tech agencies like Apple and Fitbit and the Android Googles, etc., are producing these devices that allow people to biohack their lives. Now, when I talk about biohacking, I don't mean putting testosterone pellets in the gluteus maximus or whole body stem cell transplantation, etc. I mean simple, small, pragmatic, easy to do things that each of us can do in our lives that will move us in a better direction, ultimately extending human health span. We've become so obsessed by the number of years that we live that we forget to enjoy the life in our years. So our theory, and something that the Longevity Forum is very much looking at, is this idea of extending human health span by encouraging a good, healthy life, as well as one which is long and in context. And that looks at nutrigenomics, the biotechnologies, the stress, the meditation, the mindfulness, the sleep, the exercise, regeneration, all of the little simple things that we have in our control, because ultimately the number of years that we live is not that dependent upon who our parents or our grandparents are in terms of genetics and epigenetics. 75 to 80% of that is down to our environment, the choices we make, and the people and the social community around us. Next slide, please. So how can we help people? How can we help patients lead a happy, healthy, long life? There is a 3-step process that I often talk about. The first step is to start small and start today. We each give ourselves ambitious goals, particularly on January the 1st, and we're coming up to the New Year's in a month's time. So a lot of us will be making New Year resolutions, but 92% of people fail by the 3rd week of January. And that's just human nature. And that's because we forget that in order to reach that large goal, we need to start small, but we need to start today. Rule number 2 is to stack them up and give our patients the ability to create small wins in their life, but link them up to one another that ultimately compound over a period of time to lead to long-term gain. Because ultimately humans are lazy and we always take the path of least resistance. We forego long-term benefit for short-term pleasure. And the last rule is the celebration of wins and the role of dopamine in our lives in order to celebrate and be a better version of ourselves. Next slide, please. So this is the paradigm that I operate and work within at Human Edge, where we look at all the incoming data streams that an individual is creating, either in terms of surveys that we ask or wearable APIs, open access data streams, which come into the platform. Heart rate variability, sleep data, continuous glucose monitoring, sleep I mentioned, fitness tracking, stress data, phone data, etc. Utilization of that information to build a digital avatar, a digital version of a person, should be in a position to prescribe daily biohacks to people. Simple things like, oh, we've noticed your energy level is really low. Here's a 12 p.m. snack that you can consume. And here's the recipe for that. Oh, we've noticed that you've been sitting at your desk for a number of hours. Why don't you convert your 4 p.m. meeting into a walking meeting? And here's how you can gamify it with the people around you. Or we've noticed that your sleep data from last night was really poor. Your REM data was less than 12%. Why don't you take a 300 milligram tablet of magnesium to improve your sleep for the next night? So small, simple things that people can do, and then use that as part of the digital ecosystem through content, learning and discovery, bite-sized, rich media to raise that literacy, raise that awareness, and raise the education through coaching, one-on-one coaching with life coaches to augment the patient care and the experience and the community as well, to allow people to support one another through patient support groups and gamification towards that dopamine win that they want to get. And here are just some examples, some more examples of how we achieve behavioral success. Our published framework on the right-hand side, but also on the left-hand side, some simple small things that we do with people to move upstream and better prevent the metabolic health, the liver health from developing in the first place. Next slide, please. Next slide, please. Yeah. So I'll give you a live example of how we utilize digital biomarkers to our advantage, specifically around liver edge. If you take a patient who's wearing a continuous glucose monitoring device and you notice, for example, that they see a nocturnal hyperglycemia, a glucose spike in the middle of the night. Now, clearly, if that was the only one device that a person had, it would produce an incredible degree of insight, such as either change your nighttime meal, alter the medication, such as your insulin, metformin, sulfonylurea overnight to better manage your glucose sensitivity, or get some exercise the next day to better enhance glycogenolysis. But now, if you have an Oura ring on a person and you're suddenly able to measure their sleep scores, you can then be able to be in a position to maybe see that nocturnal hyperglycemia was caused because of poor REM sleep. And it's actually the fact that their sleep needs to be improved upon in order to better manage their glucose control and therefore improve their metabolic health, drop their uric acid, and enhance insulin sensitivity over a period of time. Now you layer on their heart rate variability, and we suddenly have this incredible insight that we can look at a reduction in their heart rate variability and increase in sympathetic response, a higher cortisol load, and therefore lead to the bad sleep and therefore lead to the insulin sensitivity. This allows us as practitioners to be able to give people really personalized small changes that they can make to their life, really intelligent small changes based on data that allows them to prevent that insulin resistance from growing over a period of time and leading to their metabolic health disturbances. Last slide, please. Next slide, please. Yeah. So in summary, therefore, we are deeply passionate about living in a world where digital data has become so ubiquitous that we can now use it to our advantage as providers of care, as patient advocates, and ultimately as patients as well, to prevent metabolic disease from even occurring in the first place. And if it has occurred, then to work with those individuals to better manage their health so that we can help people lead a happy, healthy, long life to 120 and make them enjoy themselves as they get there as well. Thank you very much for all of your time today.
So thank you very much, dear professor. And with that, and with remark that we should not forget also to enjoy the years that we have, we should continue with the next thing. It's a panel discussion. So EASL Patient Synergies. We will have here a few people that will be involved into the discussion. So we have George Calamitis, the president of Liver Patient Synergies International, Eberhard Schartz, coordinator at Correlation European Harm Reduction Network. Then we have Livia Limena, European Office and IDN Director at Global Liver Institute. And we have also Eleni Antonia, who is the head of policy at Thalassemia International. And let's just start with the first question to maybe George Calamitis, the president of Liver International, to open up our panel discussion and then to go one by one answering the same question. So the question is, what does your patient organization do in order to increase health literacy? Thank you.
Well, thank you very much for the introduction, Mark, and thank you very much for the invitation to this very interesting meeting. I think before I start with the things that LPI, the projects that LPI is planning to implement regarding health literacy, I think I would like to make a few comments regarding the situation of health literacy and in general the pandemic. I think one of the good things that the coronavirus pandemic has done in the general aspect of health is that it made health come out of the closet. Health has ceased to be a boring issue that concerns only the elderly and people probably that live with arthritis or a high blood pressure. It has ceased to be an issue that concerns only patients and their caregivers and their family. And I think it has become an issue that concerns everybody. And I think this is an excellent opportunity that we need only to take into serious considerations with and organizations and institutions and individuals that are dealing with health in their daily life. The health literacy as a term has been around for many years. I think I'm 100% sure that I heard it from the previous speakers also. And in my case, especially when I was diagnosed back in 2000, and the fact that there has been, in 2000, there was poor knowledge, misinformation, or bad information regarding hepatitis C, led thousands of patients that live with the disease to postpone for years the treatment. And even though when the new treatments in 2014 came up, there was the sense that there was no a state of emergency in between the community, still led many patients not to seek up for help. The fact that there was poor knowledge, unfortunately, made thousands of patients to experience severe consequences regarding hepatitis C, and unfortunately led thousands to die from this disease. And the most sad about this thing is that most of these deaths could be easily prevented because if these people had the proper information regarding their disease, they would probably seek for knowledge and seek for help. Now coming to nowadays, this world nightmare that we are all living in reminded us in the most brilliant way that without education around health, And under also the regime of a paralytic fear, monsters can happen. Even though there is an effective, safe, and in high-income countries, easy accessible vaccines, we still experience millions of people that are reluctant in this new technology. And this is very sad because this affects, apart from the health of individuals, it affects a lot of the economies of the countries. And right now we are experiencing, again, in the center of Europe, severe consequences due to this fact. The other thing that I wanted to say regarding health literacy and what LPI is planning to do, first of all, we would like to have measurable, to measure and try to identify the gaps. Liver patients communities, even within Europe, but even more around Europe, over the borders of Europe, it is an extremely diverse community. There is the Balkans, there is the Eastern, there is the Western European Union, and all these liver patients are experiencing different difficulties and different situations. What we want to do, first of all, is to measure what are the gaps and what are the needs of these patients. And after we measure and have the outcomes, we want to design custom-made services in order to improve health literacy among the specific patient groups. Secondly, we are planning to organize a joint after COVID meeting and invite patients associations from around Europe in order to exchange experiences regarding what happened during this 1.5 to almost years of the pandemic. And this exchange of knowledge try to make the best case examples and try after that to probably implement some of those in the countries that are probably will request such services. So I hope I didn't take too much of your time. Thank you very much.
Thank you very much, George. Thank you, Mr. Kalamitis. This was an excellent start to this panel discussion. And without further ado, I would introduce the next speaker. So it's a great pleasure for me because he has a vast number of years of experience of working in the field. And I think we should all profit for that. So Eberhard Schartz, the floor is yours.
Thank you very much, Marco, and also thank you to EASL to having us, to having me. And I think that is an excellent topic to speak about and a very relevant topic also for us. Speaking about empowering patients, well, I speak for an organization or for a network, the European Harm Reduction Network. So we are not a patient organization as such, but we work with people use drugs and organizations who work for and with people use drugs. But empowering our target group and ourselves is since many, many years one of our main focus. But that does not mean only to empower them on health literacy, obviously, but in all matters of their life, as this target group is a very special one and is one which faces a lot of other threats and challenges, speaking about discrimination, stigmatization, social inclusion, and last not least, criminalization. So their life is occupied by a lot of other concerns, and the health and their own health is not always a priority in their daily life. Speaking about that, at the same time, we can see that people use drugs and organizations working with them and working for them has quite some knowledge and experiences and also focus on prevent communicable diseases as HIV, Hepatitis C, and tuberculosis in some regions. So it is a mixed picture. And what we do as a network and the harm reduction network is to provide a cascade of measures and information sharing about among our members and the broader field of drug user organizations and harm reduction organizations, quite a cascade of quite a range of actions we are doing. Just to list a couple of them. First of all, to lay the ground of knowledge for us, for ourselves, is that we conducted since 3 years a civil society monitoring on drug policies, on concrete interventions, with a particular focus also on hepatitis C related activities in organizations and in groups and initiatives of drug users themselves. So that gives us more information about the barriers, but also about the skills and the knowledge of the people we're speaking about. And we did that now for the third consequent year. So we also can see the developments, the improvements, and the gaps rising in a particular country or not. We do that in 33 countries all over Europe. Secondly, we provide a platform with resources. So because many people don't have access to PubMed, to academic literature, don't know how to find them on the internet. So we try to overcome that a little bit to present relevant information in regard of hepatitis on our website and on our platforms. Another important element is things that we need to learn from best practices, and they are all over the place. Best practices of harm reduction, which are integrated in the cascade of care and which work with people use drugs in regard of hepatitis C. So we identified around 20 good practices all over Europe out of a sample of more than 100 organizations who are doing this kind of work. And we present them as a model where we can learn from and where others can take the benefits to use the same approaches to improve their own work. Of course, we do a lot of general guidance, for example, for testing, inclusive to address the barriers and how to overcome them. We have testing manuals, and we give accordingly quite a lot of trainings and seminars. Service, partly for services directly, meaning we go to a particular organizations who ask for this kind of training in a country or in a city, and we also organize seminars and workshops in English for an European audience, to say so. Last not least, I would like to mention something what we just recently developed with a couple of drug user organizations. As you know, there is a European network of people who use drugs, and there are a lot of chapters all over Europe, and they explore certain activities, and they know very well that hepatitis C is one of the most threatening and dangerous health threats they can face during their life. So there are a lot of organizations, or also small groups, who work and to prevent hepatitis C among their members and the group of people who use drugs. And we developed a so-called status kits, testing in the community, by the community. So this is not officially launched yet. We have a draft version available, but we think that is a very important tool for the people and for organizations, small organizations on the ground, to start hepatitis C testing and the mediation to care in local settings. Last not least, I also would like to mention that we organized a hepatitis community summit, inviting community members to come together and to share the experiences. And also what I wanted to say is that, of course, this is one of our most important target group, and we are partly also part of this target group. But of course, we need also to empower or to increase the literacy of policymakers and also of hepatologists and doctors to work with the different groups and to work together with us to decrease the barriers in this regard. So there would be more to tell about, but that is for the moment. Thank you so much.
Thank you very much, Mr. Schartz, and thank you for your work. I'm sure it's extremely not easy to work in that groups and with different groups all over the Europe, different healthcare systems, and it's really good what you're doing in that. Thank you very much. So without further ado, we will call up our next speaker. So let me introduce you, your European Office and Director at the Global Liver Institute. With us, we have Livia Elimena, and the question is always the same. So what does your patient organizations is doing in the field of health literacy? The floor is yours.
Thank you, Marco. Good afternoon, Marco, and thank you to you and to Dr. Budi and EASL for inviting us and organizing this extremely interesting and very useful forum with us patient organizations. And it's nice to see some faces for the other patient organization we have been working together. Let me come and reply to your question. But before that, I would like to connect briefly with what was mentioned by Professor Diane Lewin and Dr. Marcus, because they highlighted that it is true on one hand that the problem or the issue of health literacy exists since some time. However, as Dr. Diane said, now we face an additional challenge, and that is the digital health literacy. And this is a special issue, especially for some elderly patients and their families, because we all know that our knowledge of electronic devices or technology is not the same. So this adds a problem to the long list that we already have. Before mentioning some examples on what we are doing with the Global Liver Institute to support patients and the community and empower them to tackle health literacy, let me mention a couple of things that we all probably know that can be done by doctors during the meetings with the patients to help patient to understand better what is the problem they're facing. The first thing is to avoid medical jargon or strictly medical language. As we all know, the majority of patients have a 6th-degree level, whereas a doctor is above 10th degrees level. So clearly they don't understand very well each other. Another problem is clearly, another option actually is to break down the information into more pieces and to have 3 or 4 maximum topics per visit, and to insist on them and to use the teach-back cycle so that we are sure that the patient or its parents or the people who are with the patient would understand. And finally, clearly provide some printed information in a plain, simple language and use some infographics. Like also EASL is doing recently, translating the excellent EASL guidelines into plain language for, let's say, patients, or as they would say in US, for less literate people. Regarding what we are doing, probably one of our projects that is known all over the world is the International Nash Day that I'm honored to manage internationally. And as you all know, because we partner together in this, we have among the several aspects of the International Nash Day that takes place in June, and next year will be on the 9th of June 2022. we organize webinars with the scientific community and the patients, but the most impactful action that we have are probably the patient guides. So far, we have issued 6 guides on NASH and diabetes, NASH and obesity, NASH, pediatric NASH, and other topics like that, translated into 16 languages. And these are being disseminated all over the world, even in Africa and in the villages. Clearly, they are written in a plain language. They are double-checked by medical doctors, of course, and they have a lot of infographics to support their understanding, especially because, as we all know, NASH is strictly related with obesity and bad nutrition habits. On another project that we do is Beyond the Biopsy, and that is a campaign and also some information materials for patients to go, as the name says, beyond the biopsy. So because, as you know, patients who have to do several biopsies are not very inclined because it is an invasive tool. And so in order to let them understand that if their conditions are not terrible and if they are within certain condition, they can have some non-invasive diagnostics tools. And we found with our experience that many patients don't even know that there are some non-invasive technologies that eventually can be used. As you know, we also work in the field of liver cancer, and with that, we have several projects about that around the world, and infographics and leaflets for patients. And most importantly, the last thing I would mention is our University for Patients, A3. In fact, its name is Advanced Advocacy Academy. This is a meeting twice a year when we don't have COVID. Now, obviously, it's virtual, once a year. And we gather together patient and patient representatives from all over the world, and provide information about the newest treatments, about technology to support the digital health literacy as well, and to reply to their question. Finally, we also have some newsletters, and also we are very active, but at the moment mainly in US, with the policy aspect, like Ebrar was just mentioning before me. And we have worked at the NASH Action Plan that we have shared with the federal government, and we are boosting into action for that. And that is at the moment the only example so far. So we are active on several aspects, on areas. However, you always have the impression that it is one drop of water in the ocean. So only together we can work on this. Thank you, Marco.
Thank you very much, Livia. Thank you, Ms. Alimena. So it's really hard sometimes to get into 5 minutes everything that the organization is here for and everything that you do. Thank you for your work. And without further ado, I would introduce the next speaker. So we have a head of policy at Thalassemia International. So Ms. Eleni Antonio, the floor is yours. The 5 minutes is yours. Thank you very much.
Thank you very much indeed, Marco, and a huge thank you to EASL for the invitation, because as you know, for us, thalassemia, the thalassemia community, it is very important to always share and spread the knowledge about the disease. So I would like to share my screen just to show a few slides that will ease our position and intervention. So I hope that everything is clear. For those who are not familiar with the term thalassemia, thalassemia is a type of severe anemia, and it is always treated with lifelong frequent blood transfusions, iron chelation therapy, and multidisciplinary care. And our patients, the thalassemia patients, are also liver patients, either because of blood transfusions and the risk of infection with hepatitis or unsafe blood communicable diseases. And of course, there is also the problem of iron overload. I would like to stress that the majority of the thalassemia population lives in developing countries. In these countries, most patients have low health literacy. And in these countries, the life prevalence, life expectancy of patients barely reaches the 20 years. So for us here at TIF, health literacy is equal to health education, and of course leads to a better quality of care and a better quality of life for patients. So we have been around for 35 years now, and we have grown our family and have presence in 63 countries of the world. So we are witnesses of health inequalities, the importance of health education for patients, and the importance of spreading the word and knowledge on the disease to achieve the equal and timely access of patients to quality health, social, and other care. That is our mission. And of course, our work spreads over 5 different pillars: policy advocacy, education, which lies at the heart and core of our work, networking, projects, and research. And of course, what we say is that knowledge is our power. Having said that, I would like to shed light onto TIF's educational program, which is indeed complex because it is addressed to patients, healthcare professionals, and the community at large. So we are a source of reference and knowledge for patients with regard to their disease, to healthcare professionals with regard to the clinical management of the disease. And of course, we are responsible to raise awareness about the disease. And of course, in collaboration with the World Health Organization, we try to ensure that knowledge is indeed accessible to everyone in the appropriate form, either online or offline, and that everything is provided and tailored to the audience's needs. So the language is always simple for patients, and we try to translate our resources in as many languages as possible. We aim at creating knowledgeable patient advocates. We try to empower healthcare professionals and invest in their lifelong learning opportunities. And of course, we are the main publishers of material on thalassemia, and we have a range of resources for the whole community, either whether patients or healthcare professionals. And we always try to fill in knowledge gaps. So now that we have the challenge of the COVID-19 pandemic and the fear of patients on how to act in the clinical environment, what to do, what to be careful of, what happens with vaccination, are they vulnerable or not? We had to answer to many questions, and we had to mobilize the international network of experts, our collaborators, to find the answers and provide the community with such answers. We also provide short-term courses, and of course, as we try to also address the digital health literacy needs of the community, we have developed an e-academy platform for both patients and healthcare professionals. Always disease specific, we do have our success stories, and this is the last slide. So thank you very much indeed for your patience. We have created the international guidelines for the management of transfusion-dependent thalassemia that has been translated into 14 languages and has been distributed to 57 countries of the world, adopted by several professional bodies and adapted to national needs. So around 35 countries have adapted the international guidelines and created their own national guidelines for the management of transfusion-dependent thalassemia. And of course, a very important success story that refers and concerns our patient community is the using parallel of our book on thalassemia, which is very basic and has all key information on thalassemia, the platform called the Thali course for patients, and of course, TIF conferences. And the International Conference of TIF is actually ending today. This is the last day, and it has been very successful and very important for our community with more than 1,000 participants. So based on these three resources, we have created TIF's Global Patient Advocacy Group, comprising of around 200 members, expert and knowledgeable patients. And this is what we want to improve services and make the lives of patients easier and better. Thank you very much.
Thank you very much for this excellent presentation. So it does go present everything that you do in 5 minutes, which is impressive. So thank you very much. And without further ado, I would like to introduce you to next speaker. So I was thinking a lot how to introduce a person like this. So sometimes it comes to a point where a patient is so active with his ideas or how to run the field that the field is influenced not only today, but also for tomorrow. So the way the patient organizations are established, how they communicate and what do they do, this was profoundly changed by the work of the next speaker. So it is my great pleasure to introduce you, the Executive Director of Medicine Patent Pool, and to talk on the case of viral hepatitis C, Mr. Charles Gore. The floor is yours.
Thank you very much indeed, Marco. That was a really nice and largely undeserved introduction, but thank you all the same. And I'd like to thank EASL, Maria in particular, for inviting me to do this. It's always a joy to do things for EASL, and looking at some of the attendees, some of my friends there, which is very nice. So I'm going to give you a bit of a mashup talk today, covering a bit about cancer, bit about Hep C, bit about my personal experiences around health literacy, and also what's happened in some of the organizations that I've been involved with. So hepatitis C in the UK, which is really my sort of initial experience, is perfect in some ways to talk about health literacy and to talk about the subject that I was actually given as to how it can overcome socio-cultural barriers and reduce inequities, because the groups that are affected in the UK are people who use drugs, people who used drugs in the past, and that includes homeless people, as well as some immigrant populations. So inevitably, stigma, socioeconomic inequalities, including actually low literacy levels, as well as language barriers, are also all of them involved. And of course, hepatitis C is indeed cancer causing. So when I was first diagnosed in 1995 with hepatitis C, my doctor said to me, "Oh, well, don't worry about it. You've got hepatitis C, just try not to drink too much," which I think is the first kind of lesson of health literacy, which is that if you don't get adequate information, you can't really take the actions you need. And we assume that enough information is given, or the right information is given, and very often it isn't. And then 3 years later, when I was diagnosed with cirrhosis, I wasn't told virtually anything about that either. And I went onto the internet, and the first thing that popped up was a recently published Australian paper, which said cirrhosis is the most common cause of death in Australia, at which point I stopped reading. It probably said amongst a certain group, I don't know what it said, because I just stopped there and thought, oh my God, cirrhosis is going to kill me. And I think this is an important thing about health literacy, is that your level of literacy is not constant. The moment something like fear comes in, your literacy can plummet. And that's exactly what happened to me. And I think it is really important when we're thinking about health literacy to think of the emotional state of the people that we are talking to. And of course, that's particularly true in cancer. I'm not a great fan, for example, of the word cancer survivors, because that already has big connotations for me. If you say you're a survivor of something, I think you must have gone through something where the chances of survival are very poor. You don't talk about, oh, I survived going to work today. Well, it depends what your work is, to be honest, but not generally. So once I got diagnosed with cirrhosis, I really got onto the internet in a big way. And the first thing that I found was there's so much information, which is right and which isn't. And that became a big driver for me. And then the second thing was, I would like to talk to people who are experiencing the same thing as me, because I probably trust them and maybe they talk in the same language that I do. And actually, I couldn't find either of those things. I couldn't find information I trusted in the UK or any kind of support. And that's why I got involved with setting up the Hepatitis C Trust, really to try and stop other people having to have that experience of being really unsure where to turn. And so what I did was I wrote the most comprehensive website on Hep C that I thought I could do. And I really pitched it, or tried to pitch it, in a language that was understandable and that answered all the questions I had. But having said which, I pitched it at a certain level. And for some people with low literacy levels, that was probably not appropriate. There's actually quite a useful tool on Word that allows you to assess the reading level of something you've written. And of course, there are tools out there on the internet for doing that. And it's useful. And one of the things at the time, the treatment for hepatitis C was a very unpleasant drug called interferon. And by itself, it really had very little impact, particularly for genotype 1, which I happen to have, or at least I thought I had at the time. So there was a lot of discussion about complementary medicines. And a lot of people calling alternative medicines, which I think is a very dangerous choice of words. And so we commissioned some research into what was the evidence behind some of these complementary medicines, because a lot of people were taking them. And so we put up the evidence on the website. And of course, this is also equally important for cancer, where people often turn to complementary medicines and some of the ridiculous claims out there. In fact, a very good friend of mine went off to India she had breast cancer, and she was told to do this, that, and the other, and it was all about whether she believed she'd be cured, et cetera, et cetera. And when she eventually came back to the UK, it had metastasized. It was everywhere in her. And she rang up the person in India, and he just said to her, well, it's not surprising. You just didn't believe enough. And when you fall into the hands of people like that, it's so disastrous. And so it is really important that there's some way for people to know what information is trustworthy and what isn't. And then particularly, I was always very interested in this idea of peers informing people. So people with the same experience, provided they have the knowledge, are often best placed because they can talk in a language that is understood by the people they're trying to reach. And so at the Hep C Trust, because we were often trying to reach people using drugs, we found people with a drug-using background and a hepatitis C background. And we used a mobile van, but we also actually went into drug and treatment centers, drug and alcohol treatment centers, and into prisons and trained people in there to be peer educators. And I think that that is a critical part of health education. And it's the same idea, talking to the people you're trying to reach about what they need, not making assumptions about what they need. And clearly stigma, particularly for people who had moved away from drug using, but were still very sensitive to their past. It was really a big thing about how we would reach them and what the language should be. And the UK government started a disastrous campaign called Face It, Face Your Past, which is exactly how not to do health literacy. As if people had done something bad and need to face up to it now and take their medicine. And so we concentrated much more on just simply, it doesn't matter how you got it, here's what you can do about it. Get tested and get treated and get cured. And obviously, you know, using a lot of graphics and so on. And interestingly, drug use can be quite stigmatized in prisons, and a lot of people in prison did not want to admit to having Hep C for that reason. And so again, it was really important to have peer educators that they could talk to within prison who were prisoners. And I'll just end, because we're really sort of running out of time here, on something about language. And I was involved in an EU project around screening called Hep Screen. And one of the things we wanted to do was produce a leaflet that was explained to people why they should get tested. But it needed to be done for all the countries in Europe and all their migrant populations. So in the end, we did it in 41 languages, and it was incredibly difficult to find something that was simple, instructive, avoided any kind of cultural faux pas, but it is possible to do. And it actually, we picked in the end on this idea of protect yourself and protect your family, and it's actually still available online. So just in conclusion, I guess I would say that health literacy is really important just for your health, but it's also really important for navigating your health system, which can often be as difficult to navigate as it is to understand the language of some extremely knowledgeable, but perhaps not very good at communicating scientist. And it's something that I think it's really important that we think about and are aware of. So I will stop there, and we've got, well, less than 15 minutes now to take some questions. So I'd like to introduce Professor Jeff Lazarus from the Barcelona Institute for Global Health, who's also vice chair of EASL's International Liver Foundation. Jeff, can I hand over to you?
Great. Well, thank you very much, Charles. And you're right, we have very little time. This is the second time today, as Maria knows, I've had to tell a group of patients dealing with liver disease in Europe that we have very little time for the discussion. I think that's got to be a record for one day. But there's really nothing I would have cut. I mean, I think this was incredibly important. And from the EASL side, where I sit on, with Maria in the Public Health and Policy Committee, I mean, this is us getting the discussion going. So, I mean, we've heard, we've listened, we'll prepare some notes and feedback, but obviously this conversation needs to continue and needs to continue for a long time. Let me just put out a question to everyone. The COVID-19 pandemic, which has been so sort of all dominating for us the past year and a half, has impacted on health literacy. And some people say, well, the good news of the pandemic is now that everyone in the world knows what a pandemic is. The bad news is there hasn't been a lot of time to deal with some of the pandemics and conditions affecting us in liver health. And so I'm just wondering if some of the representatives of the organizations, from your organization's perspective, can tell you how you think the pandemic has impacted specifically on health literacy. And I think I see Eleni has a hand, and then Diane. So go ahead, Eleni.
Thank you very much. Indeed, the COVID-19 pandemic was challenging because initially it was an unknown field for everyone. So nobody knew what are the challenges and what we need to pay attention to. So we had to mobilize so many people and so many experts and try to create the patient's pathway to the clinic and the transfusion center to ensure that everyone is safe, especially patients and healthcare professionals. And indeed, the gap, the knowledge gap created fear of the unknown, created fear of what comes and what creates risk for the patients. So whenever such a challenge arises or comes up, only health education can actually help and support the patient community. Thank you.
Great, thank you for those words, Diane, and then Eberhard.
Yeah, I'll be brief. I think it's a great question. And I think it's the beginning of a long-term discussion. But just a couple of points. I think there is a silver lining. I guess we all want to be optimistic as we serve the public. And I think firstly, we're seeing that there's communication avenues that have opened that we didn't know existed before. I love the quote, and I'm going to quote George, that said, "The health has come out of the closet." I'm going to use that and quote you. It's true. I think we have seen that the nomenclature has changed. We began talking about mitigation and to make the curve, change the curve. But I think in time, the politicians and the policymakers and the providers realize we have to change the language. We need to listen to the public. We need to have culturally appropriate language. We have to respect cultures. And I think that's going to last, and I really hope it will. And finally, I think there's an element of solidarity, and I hope that we can carry that over, because what we do for our health, as far as COVID, affects our entire communities, our families, and maybe there has been something that will last, to say that we're all into this together. This time it's for Corona, but it can be for liver disease, it can be for healthy lifestyles. Healthy lifestyles are communicative. Smoking is communicative. And physical activity is too. We affect each other, we influence each other, we create the norms. So I think if we're careful and if we're lucky, and if we invest in it, I think we can have a silver lining come out of all of this. Thanks.
Thank you, Diane. And you started to answer Achim's question in the Q&A, which was around cultural translation in a country. And I think we need to remember that it's not just for the countries, it's at the subnational level. So many of our countries, even when we speak the same language, are so culturally diverse that we need that kind of health literacy really tailored. So I see Eberhard, then George, then Livia. We'll keep it brief, unfortunately, but there'll be more opportunities.
Yeah, so very shortly, because there were some also in the sector of harm reduction, also some positive developments in terms of awareness and also in regard of health literacy, and also in terms of acknowledgement, harm reduction services as essential services during the pandemic. So that could be maintained, or hopefully that can be maintained after the pandemic, and that would be at least a little positive aspect of the entire story.
Thanks, Eberhard. Over to you, George, and then Livia.
Yeah, I think one of the good things that this pandemic made is that it made to the world very familiar with terms that we've been fighting for years, like screening, testing, cases, prevalence. And I think this is important because, we were trying to fight for, to adopt screening policies and convince policymakers and even the general public to introduce policies to deal with communicable diseases. And now I think everybody understands how this is important. The other thing that it's in my concern, I think that everybody's concerns also, is that the unregulated environment of the social media had a significant impact in the health literacy of people. There's a bunch of tons of information that nobody can, information that is not credible, of course, that nobody can regulate right now. And the common characteristic of these groups that share such information is that they approach in a more empathic way individuals that are out there. Unfortunately, I have seen from the scientific community that if somebody, disagrees or, has questions regarding even vaccines or any other cases regarding COVID, they are very district and they are not open at all to the conversation. And therefore, individuals that have questions or fears regarding new technologies or anything that's related to COVID are easier approach from groups that share misinformation and fake news. Thank you.
Great, thanks, George. Livia briefly, then Marco briefly, and then I'm going to read a couple of the questions and answers, but then I'm going to close and pass back to the chairs.
Sure, thank you, Jeff. Very, very kind of you. Just one word, the main things has been said. I wanted to add one item to the question from Achim, since we also have some experience in multicultural environment. One thing I would say that is very important that we all know is the holistic approach. So to sit all together and work together and also adapt our language to the culture and the environment of the country, as we all know. This means to do things not top-down, obviously, approach, but I would say bottom-up, at least I would insist on the holistic approach and clearly the inclusion and the empathy that were already mentioned. Thank you.
Thanks, really good points, Livia. Marco?
Oh, thank you very much for the floor. So just a short comment regarding the COVID, positive side of COVID. So one thing that we saw in the policy that the doors are now widely open. So it's not necessary to talk into silos. So for people who already know what is the problem, but with the COVID, we have an open door to go out to the decision makers, to the stakeholders who are really important in making decisions about healthcare and present our cases there. I think that's the biggest positive side of the COVID, if I look at the positive sides. Thank you very much.
Thanks, Marco. So, there's some good questions and answers or questions at least that we're not going to get to, but let me just read them briefly for the record so we have some of our agenda for the next time we meet. So Dr. Mojca Matic in Slovenia said, information coming from patient organizations and other civil society organizations may serve not only as an important health literacy tool for patients themselves, but also for policymakers. For example, the monitoring of progress in managing HCV that Correlations EHRN runs. And Raquel Peck wrote, in terms of education around the liver, are there new successful strategies being deployed to create awareness about this organ? Typically, when you mention liver, it does not carry the same urgency as brain or heart. So those are really good points. I'm going to thank everyone for this, well, I think two brief discussion on behalf of Charles and I, although I think I did most of the moderating. And I'm going to pass back to you, Marco, and to you, Dr. Maria Butti, to close this EASL session on health literacy. Thank you.
Thank you very much, Jeffrey. So as always, we have just started the conversation and probably this will spark new conversations, new ideas of what to do or what to talk about. So I just want to say in the name of the patient organizations and patient representatives, thank you for EASL for having this initiative. And thank you for setting up this kind of format to be able to communicate with each other. And thanks to all the panelists. Maria?
Thanks, Marco. Before closing the meeting, I would like to ask all of you to open your cameras just to have a photo of all of the group. Thanks. And I would like also to thank all of you to participate in this patient forum. I think this is a beginning of a new topic. We have to work more on this, and I am very, very happy to collaborate with all of you, and EASL is supporting patients organizations, and I think we have to continue doing this. Thanks a lot, and have a nice evening.